Hello everyone, welcome to this presentation by A Physician's Cup of Coffee, Part 2 of ABG Interpretation Series and Part 3 of ABG Problem Solving Session. The scenarios have been taken from ward work, from online resources such as textbooks, and anesthesiamcq.com, Life in the Fast Lane, Dr. Dillon and Dr. Smith's teaching videos. So I have said previously that you would be able to interpret any ABG scenario, however complex, if you follow the step-by-step interpretation described earlier. So the question is, can I actually walk the talk? Let's see. The approach that I have described has been tested again in numerous scenarios, and a selected few have been shown here. I've been able to arrive at the same assessment as the authors in terms of blood gas interpretation, but at times by a bit different approaches. So then have a listen and you can decide for yourself. Over the years, I've gained so much from so many. Some amazing people in my life who have cared with boundless love. Eternally grateful I am to them. I'm also thankful to the teachers who have given without holding back. So, can I give something back? I certainly hope so. Hopefully, this will be helpful to some young physicians in their clinical journey and in their exam preparations. That for me would be amazing. So this would be the step-by-step approach that we would be following, and I've explained this in detail in part 1 of the video series. Have a listen. So this would be the order of results as previously. Sometimes not everything is as it appears. It can be normal or it can be just the tip of the iceberg. Can we work it out? Let's see. We've actually worked out this ABG in the previous session. The reason I'm showing it here is it's got some context. I'll show that in the next slide. But you look at the pH. It's within the normal range, right? When you interpret an ABG, I've mentioned before, the ranges don't help. You have to have a fixed number. But the pH here is within the normal range. But when you look at the PCO2, it's slightly below the normal range, and bicarb is slightly below the normal range as well. But here we diagnose that the patient has a triple disorder. Okay, now just remember that. Okay, now looking at this particular slide, the case scenario 18 has been presented at the bottom. That's the one that we described in the previous slide, but just have that in mind. But going to scenario 19 at the top, look at the values. Okay, the pH is within a normal range. Okay, having said that, I'll say you cannot interpret an ABG with a range. You have to have a fixed number, but there is a purpose to what I'm saying. So now the pH is within normal range. If you look at the PCO2, that is also within normal range, but the bicarbonate is slightly below the normal range. Okay, so does this patient have anything? So this is, I think, a child who had come into them with methanol poisoning and subsequently was evaluated, and they in fact went on to do a urinary or smaller gap assessment, but the final assessment, but this was a normal ABG, normal interpretation of ABG. There was no acid-base disturbance on the ABG, but I would have a slightly different approach to that. I mean, those authors, this is from anesthesiamcq.com, extensively experienced. Depth of knowledge is extensive, so I'm not like saying arguing about the assessment, but it's just that I look at the pH. Okay, it's slightly, I mean, my normal value being 7.4, I'll look at it, okay, maybe slightly on the higher side. PCO2 slightly on the lower side, so I would suspect maybe a respiratory alkalosis, but I also note that this patient's been tachypnic, so that can explain that. But then I go and look at the bicarb. for that level of PCO2, the bicarb is pretty low. Okay, so I would suspect that this patient maybe has underlying metabolic acidosis. Okay, in this context, that's a possibility. But however, they have gone on to look for the osmolar gap, and that's after everything they say this is a normal ABG interpretation. That's fine, but just have it in your mind that this patient could have respiratory alkalosis secondary to tachypnea, but the bicarbonate has not dropped enough. Maybe it's still an acute process, not yet moved. That's something to be kept in mind, but I would actually repeat the blood gas at the end of all the treatment to make sure the child is alright. So that's about the slide 19. Okay, looking at the slide 20, that's in blue. Now look, every value is bang normal. Okay, every value is bang normal, but then you could say this is a normal ABJ. Okay, but then you look at the anion gap and then you see that the huge anion gap. Okay, so everything being normal, I've spoken about it earlier. If the anion gap is high, then that's high anion gap metabolic acidosis. Okay, then you would go through the steps to look at the delta ratio to identify an additional disorder, and before that you would have used Winter's formula to see whether this patient's got a respiratory component there as well. Okay, so looking at all that, so this patient, the other point I wanted to emphasize is, I think this is from Dr. Smith's video. Look at the chloride, it's around 86. Okay, so he is emphatic in saying that if there is hypochloremia in relation to the sodium, then that patient has got metabolic alkalosis. But I'm not that confident in saying that, but I would strongly suspect that this patient could have a metabolic alkalosis, and that's what this patient actually had. If you go through steps and do a delta ratio or the equivalent methods for delta ratio, and then you will identify additional metabolic alkalosis. In the previous slide, at one place while explaining, I had incorrectly mentioned that maybe the bicarbonate has not dropped enough, but the correct way to explain would have been bicarbonate has dropped more than expected for that PCO2. So the bicarbonate is low, giving us a suspicion of an underlying metabolic acidosis. The concept is clear, but the way I'd mentioned is, I should have said the bicarbonate is too low for the expected PCO2. Alright, here again we've got a couple of normal looking ABG results. Okay, so when they are normal looking, you can't just, clinical context is king. Okay, that's very important. You can't just do an ABG on somebody just walking into the ward, like a patient's uncle walking into the ward. You call the uncle, do a blood gas, and then say, oh, you're going to interpret and say he's got a complex triple disorder. That's now how it works. Clinical context is everything. So looking at the first patient, the normal pH, and but both bicarb and the PCO2 values are abnormal. So I always go with the PCO2 first. So whichever way you do, even if you do the bicarb and then come through the Winter's formula, that patient's got a metabolic acidosis and respiratory alkalosis. I would have said he's got a respiratory alkalosis and metabolic acidosis. That's fine. The second patient, every value is normal. Okay, so normal pH, normal PCO2, normal bicarbonate. This is the uncle walking. It could be the uncle walking into the ward and everything is normal, or this could be a really unwell patient. Here, then you go do the anion gap, and then you find that he's got a anion gap of 27, which is on the higher side. Then you do the respiratory Winter's formula for respiratory compensation. Then because it's a HAGMA, only because it's a HAGMA, you do the delta ratio, and then you identify this patient's got a metabolic alkalosis hidden there as well. So that's how we would approach a normal looking ABG. Here, the ABG scenario is actually to demonstrate an acute and chronic process. Alright, so the pH is on the lower side, PCO2 is on the higher side, so we know that the patient's got respiratory acidosis. Whether it's acute or chronic, for that you need to know the delta PCO2, which is 45, and then you know to know the correction factor. Okay, I've shown the steps clearly. If it's a chronic, and the pH, if it's purely chronic, you expect the pH to be 7.265. How that is, I've shown there. And if it's purely chronic, you expect the bicarbonate to have risen to 42. And then if it's purely acute, you expect the pH to be at 7.04 and the bicarbonate to be around 29. Okay, and here the values are in between an acute and chronic. Okay, so it tells us there's an acute on chronic process going on here. Why do we need to know this actually? Is there any reason that we need to know this? How do we do that? I've shown you. Why do we need to know that? Down the line I'll show you with an excellent example in day-to-day practice. Here my approach would be, I will look at the pH on the higher side, PCO2 on the lower side, so straight away I would assess that my patient's got a respiratory alkalosis. The next step, I would look at the compensation. The bicarb is way high for this PCO2, so I would know that my patient's got a metabolic alkalosis. Then of course you look at the Anion GAP, which is HAGMA. So okay, I've straight away made the diagnosis of a triple disorder by using the approach that I described. But many authors do it in a different way. They look at the Anion GAP, which is high, then they use the Winter's formula, and then they come to the delta-delta ratio because it's an HAGMA, and then assess with an atom as an additional metabolic component. But here, if you use that process, I'm not saying that's wrong, you could do that, but if you do the delta-delta ratio, that's not going to be contributory because it's 11/16 would not be giving you a ratio that is compatible with metabolic alkalosis. Okay, so what do? Here you got a chloride that's significantly low in comparison relative to the sodium level. Okay, you strongly suspect this patient's got a metabolic alkalosis. In such situations, if you come through the Anion GAP pathway as the primary metabolic acidosis as your primary diagnosis, then I would suggest that you use the alternative methods to confirm or to exclude the presence of a metabolic component here. Okay, that is metabolic alkalosis. So if you actually follow the steps that I have been talking all through, you would actually reach the triple diagnosis within no time. Alright, so this is actually, by now it should be pretty straightforward. Okay, so by looking at the pH and PCO2, we come to a primary diagnosis of metabolic acidosis. Then you use the Winter's formula for compensation. You find out that the Anion GAP is HAGMA. You do the delta-delta ratio. It gives you an idea that you got an additional NAGMA. Okay, so you already come to a diagnosis of triple acid-base disorder. Okay, so this is just for the practice of the alternative equivalent methods for delta-delta. Okay, one of them actually confirms that there's got a additional metabolic NAGMA, and the other one actually doesn't. But you will normally use all three, and then based on the clinical context, you utilize whatever is appropriate for that particular context. So here you got an AGMA with adequate respiratory compensation and additional metabolic NAGMA. Okay, here can you spot the wolf among the sheep? Okay, so everything looks normal. This could be the patient's uncle walking into the ward happily, or this could be a patient who has got a complex metabolic disorder, HAGMA plus metabolic alkalosis. This has been explained previously. Try it yourself, see whether you could work it out. Okay, this one we've worked it out previously as well, but essentially patient who's got acute respiratory acidosis, probably head injury, and then subsequently hypoventilating, okay, or respiratory arrest, going into a respiratory arrest. Okay, so but my other concern would be this patient's bicarb is without it's not compensating, but it's actually going on the lower side. Okay, they've got a base deficit, so that is something to be kept in mind, that these patients got an underlying metabolic acidotic process going on as well. This is an excellent ABG from Life in the Fast Lane. They've got some excellent clinical material. Have a look. Okay, so they have actually categorized this as a tricky ABG. So when you look at the pH, it's on the lower side, PCO2 on the lower side. So I would say a patient got primary metabolic disorder, Anion GAP normal being NAGMA. So I look at Winter's formula for compensation and identify a primary respiratory acidotic process going on, because the PCO2 is much higher than expected for the compensation. Okay, so but why do they say this is tricky? But look, the patient's got metabolic acidosis, which is categorized as NAGMA, but then when you look at the lactate level, it's pretty high. Okay, so that's why they've classified it as tricky. Okay, so in this situation, what would be your approach? Okay, have a think before we go into the next slide. Have a think of what we've discussed previously, and based on that, what would be your thoughts? Now, continuing from the previous slide, so it was something that a patient had a normal Anion GAP metabolic acidosis, but the clinical context and the lactate level was high, suggestive of a high Anion GAP metabolic acidosis. So in such a situation, what would be your thought, or what would be your approach? The first thing I would do is go back and look at the albumin levels, because hypoalbuminemia is a situation where you could have a falsely normal Anion GAP result. Okay, so you have to correct it based on your albumin correction. How do you do that? I've explained that clearly in previous videos. Please have a look. Then the second thing to consider is for other conditions where you could have a falsely low Anion GAP situation. Okay, again, what are those? I've explained that in previous videos as well. Please have a look of the first video, and then you would understand that. But remember that hypoalbuminemia is one such situation, and in lactic acidosis, 50% of the time the Anion GAP will appear as normal. These are things to be kept in mind. Have a look at this ABG. Is this the happily looking uncle walking into the ward, or is there a wolf hidden among the sheep? Try and work it out. There was a scenario number 11 in the problem solving session which got misplaced. I was pretty upset about that I couldn't actually present that to you all, but then this scenario came up, which is another excellent one in terms of clinical context and day-to-day medical registrar's ward life. Okay, so have a read. This is about a patient's suitability to be transferred from the ICU back to the wards or from the ED to the wards, about the medical registrar's decision-making thought process. What is the concept even being tested here, and what are your thoughts? Have a think before you go to the next slide. So that brings us to the question, what is the concept being tested here? So the issues are, how do we do that and why do we do that? How do we do that? I've just now explained in previous slides and in previous videos in an extensive manner. You will have to go look it up. Okay, why do we do that is what the discussion that would follow now, and I would try to explain the concepts. So to work that out, we would have to know what would be the pH change in a purely acute situation, and what would be the bicarbonate compensation in a purely acute respiratory acidotic situation. And then we will also would have to know, to work out what would be the pHb in a purely chronic respiratory acidotic situation, and what would be the range of bicarbonate compensation in a purely chronic situation. Having worked out for an acute purely acute and a purely chronic situation, then we then go on to compare those values to our patient's values. Okay, that based on that we come to an assessment that our patient's PCO2 is very close to their usual stable PCO2 level. We have assessed that our patient's current pH and current bicarbonate are very near a chronic stable state rather than an acute decompensated state. By that, we are able to assess that our patient's PCO2 would be also very close to their usual stable state. So they are well on their way to recovery, and we would be quite comfortable in transferring them back to the wards. Well, if you listen to all the videos and if you diligently follow all the steps, congratulations, you are now ready to be called the boss of blood gases of the wards. Now that you are the champion of blood gas interpretation, go to anesthesia.com and look at their examples given and their scenarios and see whether you can actually arrive at their assessment using the method that I have described. Have a look and try. I will be immensely happy if it has been of use to anyone. If you liked it, kindly hit the like button and subscribe. These are the topics I plan to discuss in the near future. If there's anything in specific you would like, kindly let me know. There are people in my life who have given me immensely through their love and sacrifice. I think of them with gratitude every day. Thank you.